Professor Khosrow Adeli is head and professor of clinical biochemistry at the Hospital for Sick Children at the University of Toronto in Canada. He is also senior scientist with over 30 years of experience in clinical chemistry, service education, and research. He currently serves as IFCC president and editor-in-chief of Critical Reviews in Clinical Laboratory Sciences. Professor Adeli has been active in both fundamental and translational research, publishing over 600 articles and abstracts to date, with major intellectual contributors to the fields of medical health and disease, as well as clinical biochemistry and pediatric laboratory medicine. Academic achievements have been recognized through several prestigious research awards, both nationally and internationally. Thank you, Khosrow.
Thank you very much, Giuseppe, for your excellent presentation. I'm here to present to you the next topic, which is serological testing. As you know, this is particularly relevant to clinical biochemistry labs. Many hospitals have serology testing done in biochemistry. In some hospitals, it's done in microbiology, but it is very relevant to our field of biochemical monitoring and immunochemical and immunology assessment of patients. And so I'll present some of the, initially a very short introduction and then followed by an actual review of the guidelines that are being published by IFCC. This is on behalf of the Task Force on COVID-19. And I wanted to thank my fellow PhD fellow, Mary Catherine Bone, who has been really helping with both the guideline development as well as our presentations. As you know, immune response is very important in patients with COVID-19. And of course, the hope is that we can actually use this immune response and development of antibodies and in the future using vaccines to be able to hopefully resolve this disastrous sort of pandemic around the world. So understanding the immune response, the antibody response is very important. This slide tries to just summarize that when the virus is infecting the cell, it normally uses a protein called a spike protein. So here I'm showing the virus and the spike protein, which is actually known to bind a receptor called ACE2. And ACE2 interaction with the spike allows the virus to actually enter the cell, the host cell, and that host cell then triggers usually replication and production of the virus, so it amplifies. So now you have million more viruses. So even if few cells are infected, you get a very large amplification. And these viruses are then recognized rapidly by our immune system. And the first cell that typically recognizes these viral particles are called antigen-presenting cells, or APCs. These in turn are actually able to trigger T cells, these T helper cells, which T helper cells are very important in our sort of immune response, and they trigger B cells, which are actually antibody producing cells, to differentiate either to plasma cells or memory B cells. And then they in turn produce antibodies. So these antibodies are then measured in serological markers. So this immune pathway is really, immune response pathway, really important to our response to the virus, and also being exploited to develop vaccines. Now, serological testing, as you know, is becoming extremely popular, and there are many assays developed, and they are largely used not as diagnostic assays, and that's important to realize that they can really be used to diagnose presence of the virus or the presence of the disease, COVID-19, but they are important in assessing viral exposure and past infection. And this can be important, as we will see in the next few slides, that this can be important in public health management. Serological tests are therefore not appropriate for early diagnosis, but they can be very important in long-term monitoring of the population. Now, there are multiple approaches to actually doing the serological assays, including rapid or point-of-care assays, which usually are based on lateral flow technology, and they tend to be becoming more popular and are better, but overall they have not performed as well as some of the lab-based assays. Lab-based assays shown here are usually based on either ELISA, which you're all familiar with, or chemiluminescent immunoassays. And these tend to be either qualitative, mostly qualitative, but in some cases, quantitative assays have been developed that could be particularly useful. In addition, some labs, mostly research labs, have developed neutralization assays. These are actually based on cell culture, where you can actually demonstrate ex vivo that, for example, antibodies present in plasma or serum of a patient can actually neutralize the virus, prevent infection and growth of the virus. And that's called a neutralization assay. And these are, for example, here in Toronto, there are a couple of groups that are performing neutralization assays, but in general, most labs tend to use ELISA or chemiluminescent immunoassays to perform these assays. Now, there are different types of immunoglobulins that can be measured. As you know, you could look at IgM, which tends to appear earlier, and then IgG, which is tend to be the main target of most assays. There are assays where you can measure all IgM and IgG, as well as IgA, which is less commonly measured. So there are these total antibody assays, but the ones that have become most popular are IgG-based assays. Most manufacturers develop these assays against either the spike protein, so these are antibodies against being measured that are against the spike protein, which, as you know, involved in the infection and the receptor binding, but also some assays are actually measuring antibodies against the nucleoplasmic sort of proteins. And this diagram shows that there are different types of key proteins. The spike proteins involved in the interaction with the receptor, as I mentioned, but the others are mostly structural proteins. Nucleocapsid proteins are actually involved in RNA binding and basically forming the genome of the virus. Now, this is a slide, many of you, I'm sure, have seen this, shows the actual sort of antibody response or immune response in a typical patient. Usually, when patients are exposed to the virus, they initially show presence of infection, and this could be detected by molecular testing that Dr. Lippi just presented on. So you could measure the RNA and be able to detect these patients. But typically, antibodies are not yet present. So that's why it's important to perform serology testing at the right time. Usually, after a couple of weeks, there is a response that's initiated, and this could be is shown here, mostly IgM and IgG. IgM tends to, in some patients at least, tends to appear earlier, and it's been suggested to be potentially an early marker. But IgG is the prominent response that then is measured by multiple assays that I mentioned. Now, later, it's been shown that some of these responses can actually may not be necessarily stable, in the sense that over time, some of these antibodies may decline in levels and then become undetectable. But as we will hear from Dr. Horvath, when patients are actually hospitalized, they are also monitored by multiple other assays. So beyond molecular and serology assays, biochemical hematological testing is also very important in monitoring these patients. Now let's focus on the guidelines. The guidelines that have been just basically submitted and accepted for publication and coming out soon is talking about some of the key aspects of serology testing. One is clinical indications. So when do you perform serology testing? Assay selection, assay verification, test interpretation, and limitations. Now, this slide tries to talk about some of the clinical indications. The guidelines recommend that the following cases should be good candidates for serology testing. First, as an adjunct to molecular testing in patients presenting with clinical features, but the tests, their viral RNA test, is actually negative or undetermined or unavailable. So serology testing could be helpful in those patients. Or as an adjunct to molecular testing where persistently positive molecular tests occur, but there is no, in the absence of actually the infectious virus, such as late after result infection. So there are some cases of that has actually confused people doing the molecular test or the serology test. And these are cases where I think performing both molecular and serology tests can be useful, as well as finally in children, particularly with this condition called multi-system inflammatory syndrome. Many of you, I'm sure, we have heard of children developing, more and more children actually developing this condition. In the US, it's in the thousands of children that have been diagnosed with MIS-C. And this slide tries to explain what that is. And this is a nice review on the topic in Cell, as well as in New England Journal of Medicine. We also have published a review on this in the Journal of Physiology. Basically, there is a number of reasons for calling this disease multi-system inflammatory disease, and that is because of the fact that these patients present, and this on the right here, we have listed here a number of basically definitions, the features. The definition is that these patients tend to be under 19, so regarded as children or adolescents, have fever for usually more than 3 days. They have clinical symptoms, signs of multi-system involvement. Actually, many of them have cardiac marker elevations and GI issues, and then elevated markers of inflammation. But when you actually look at microbial infection, it's not typically seen, and it's therefore not thought to be a bacterial-induced inflammation. But there is, depending on the child, in many cases you find positive RNA results, so positive molecular tests, positive serology, and even in cases where antigen testing has been performed, positive antigen testing. And there is evidence in some cases of contact with an individual with COVID-19. For these reasons, this group has been defined as having this multi-system inflammatory disease. And actually, it's interesting that in a recent study, it was shown that these patients present weeks, usually an average about 5.2 weeks after the initial exposure. So they don't immediately appear to show any clinical features, but they develop this multi-system inflammation late, several weeks later. And here on the left, the number of other aspects have been addressed. For example, cytokine profiling. And here, actually, in our children's hospital, we monitor children with this condition with cytokine profiling, and you can see significant evidence of inflammation, not only increased CRP, increased ferritin, but also increased cytokines. Now, there are a number of also recommendations around clinical indications that might be possible down the road. And this is a list such as identifying prior infection in non-hospitalized individuals, so-called seroprevalence surveys. And this is actually something we're trying to do here in Toronto. We're starting a pediatric or children seroprevalence study in the Toronto area. Also could be potentially used to quantitatively evaluate the degree of antibody response, but of course this requires good quantitative assays. Also could assist in identification of immunity, but I think we're not there yet, but that's a hope or potential, and the progression to herd immunity eventually that could hopefully resolve this whole issue and prevent some of the current lockdowns if we actually indeed develop herd immunity, but that could be years ahead, years from now, and therefore hopefully vaccines initially would help before herd immunity is developed. To assist also in identification of potential convalescent plasma donors and evaluation of antibody response to future vaccines. But what's not supported by evidence is to diagnose infection in acute phase of the illness, and I think I've already mentioned that. Now, there are a number of recommendations also on assay selection, that there is no evidence that any specific type of antigenic target or immunoglobulin isotype makes a difference. So therefore, assays targeting different isotypes could be acceptable, as well as those measuring IgG or IgM. Although, as I say, IgM is much more popular. There is also no commercially available test that has proven capability to actually detect neutralization antibodies. And the current, as I mentioned, point-of-care assays have shown, at least initially showed poor sensitivity compared to lab-based assays. But this is changing in the sense that there's some improvements that might make point-of-care testing more valuable. Now, for sake of time, I'm going to go quicker. Also, in terms of regulatory approved assays and verifying them, there are a number of parameters that have to be assessed, analytical parameters, clinical parameters, desired sensitivity, desired specificity, and also participation in a quality assurance program, which are becoming more available. And then even reporting is critical. And this next slide provides some information, but the much more detailed information is available in the publications that are coming out in the next couple of weeks. The guidance is focusing on basically recommendations around verification of regulatory approved test performance. And it's not meant, by the way, for verifying lab-developed assays. It's meant for commercial assays that have manufacturer claims, and these guidelines provide some practical steps on how to actually assess manufacturer claims around these assays. And then most of the current serological assays are actually qualitative, and this is changing because I have seen some quantitative assays coming out recently. And of course, labs have to consider local resource availability. And so I think that's one feature of the IFCC guidelines. It has tried to be practical to try to assist labs around the world with different resource capabilities and availabilities. And so it has tried to make the guidelines as practical as possible. Now, in terms of analytical performance, I think many of you know some of the parameters that are assessed in precision, carryover, cross-reactivity, interference, but also participation in a quality assurance program, and there are several available now. CAP has come up with programs and others such as One Word Accuracy, SeraCare, and there are a few others. We also provide fairly detailed guidelines around analytical verification. There's no time to go through all of this, but it will be available shortly for you to review yourself. And so it talks about how to assess precision, carryover, cross-reactivity, and interference in relation to basically COVID-19 serology. Also, in terms of clinical verification, of course, it's equally important to analytical verification. And it is important that one actually verify manufacturer claims around clinical sensitivity and clinical specificity. And the components that have been proposed in the guidelines to be assessed and factors that could influence sensitivity and specificity are things like patient setting, whether it's an inpatient or outpatient, severity of the disease, whether the patient actually has significant symptoms or not, the timing of assessment, and reference comparator, having samples of known positive and known negative exposure. And then more details around clinical verification has been provided, but it is important to note that our recommendations in these guidelines that are coming out is meant to verify manufacturer claims, which are largely based on hospitalized patients. So it is important to realize that if you use other samples, for example, from community subjects that are not hospitalized, you may get different levels of sensitivity and specificity. So it is important that the population be taken into account. This is actually a nice slide that tries to demonstrate that in a sense that you could look at the positive, true positive, false positive, true negative, and false negative rates, depending on the population you're testing, and of course the test characteristics. On the right here, as shown, the actual positive predictive value significantly increases as the prevalence in the population increases. So of course, hospitalized populations have higher prevalence, those hospitalized with suspicion of COVID-19, compared to the general public that have much lower prevalence. So therefore, a prevalence of the condition can significantly affect positive predictive value and negative predictive value. And that also actually surprisingly starts going down slightly by increasing prevalence. Now, in terms of interpretation, there's also guidelines provided around how to report a test positive or negative or indeterminate. And so some details have been provided in that regard. Now, in terms of the strategies to improve positive predictive value, which is really the aim of the clinical lab, is to first to restrict testing to high-risk populations rather than trying to test everyone. Although, as I said, seroprevalence studies are starting to be recommended in some populations, for example, in children that we are planning to do. We have actually already started with some preliminary studies. And then performing orthogonal testing, where initial positives are tested by a second method, in the sense that you want to confirm positives using a second serology assays. We're doing that here actually at our hospital for sick children, and we're using a different assay that actually targets a different part of the viral protein. And so this is called a different antigenic target. So using two different assays, targeting different proteins within the viral particle can be useful. Also, it is important to keep in mind patient age, immune status, exposure history, and potentially ethnicity. As you know, many ethnic groups have been particularly affected in the US and even here in Canada and elsewhere. For sake of time, I'm going to move on because to give time to our third presentation. So in summary, the guidelines are based on evidence. By the way, a very major literature search was performed and extensive discussion held by not only the task force members, but we also have many corresponding members as well as several diagnostic companies that have provided comments. So the guidelines are based on extensive consultation with over 20 different people, including 5 different industry colleagues, partners. And so we have really extensively reviewed the literature and provided evidence-based recommendations. And these hopefully would be of help to particularly developing countries and clinical labs around the world. Now, additional items for consideration in terms of testing in the future is test harmonization, improving point of care assays, which I think that's critical in many rural communities, and quantitative serological testing. What's not mentioned here is antigen testing, and I think it should be also considered as potentially a game changer. It could, rapid antigen testing is already coming out, and I think it's going to make a difference in terms of turnaround time and monitoring the population. So the task force will continue to evaluate the emerging evidence on these and other testing paradigms, and it will develop guidelines in the future. So the current guidelines are interim and will be updated shortly. So thank you very much.